If you see these gripping images, there's no greater joy, no greater fulfillment than to serve this incredible mission of Mercy Ships. Distinguished guests and friends of Mercy Ships, sunshine since we arrived 11 days ago here in the port of Rotterdam. And many are wondering if this is the usual weather of the Netherlands. Yes, it is. And you're most welcome to live here the rest of your life. Thank you for being here in these difficult times. And if you allow me to introduce myself, my name is Jan van den Bos. I'm the chair of Mercy Ships Netherlands and one of the vice chairs serving this incredible mission. And it is a tremendous honor and a privilege to receive you on board of the Global Mercy on behalf of Mercy Ships Netherlands, and to share with you the vision of Mercy Ships and the charity to those who need it most. We know that an international medical community, that you always have been very much engaged to improve the care worldwide, especially to those who need it most. This is a ship of mercy, and I proudly call her the Empress of the Seas. Most of you have been involved in the global experience, and if you visit, speak with the 11,000 visitors that experience the global mercy, you see the wonder in the eyes of people, tears, and so I have. I know even more that our mission of today, bringing hope and healing to the world, is so important. We are also aware that in these times our worlds are closely connected, especially the medical world, as we see today the ongoing suffering in Ukraine. In our mission, two things are really of the utmost importance: to have a purpose that leads to a promise. And there's no better day than today to realize how important purpose is in life and also how fragile it can be. 40 years ago, I met a man, and I thought, when he presented his dream to me, it's an impossible dream. It's not possible. His name is Don Stevens, one of my heroes, a man that is close to my heart. He invited me to become part of his dream. And today we are on the Global Mercy, and one of his dreams came true. And you're part of that dream. And the vision of one man can change the life of so many. We have over 1 million friends on board that we could give medical or surgery, and it is really mind-blowing. I'm not from the medical field, and please excuse my poor English, but I have seen the poorest of the poor coming on board our ships. I have seen, and I had the privilege to be in the operation rooms with Dr. Gary Parker, seen patients that came with tumors that I thought it's impossible to rescue lives. And I've seen them leaving our ship with new hope and new lives. And that is Mercy Ships. The surgeries that we provide are not a finish line, but the start of a transformed life. And we see that in all the images you will see and you have seen. During our visit in Rotterdam, we have really treasured also your warm welcome and enthusiasm about what we are able to show here on board. And let me tell you, it's a great undertaking. We have over 60 events, 11,000 visitors. We have 111 countries that follow the virtual tour. We have over 50 million hits on social media. So the excitement and the joy is enormous. And thank you for being part of that. But my true heroes, and hopefully for you too, are the volunteers that serve on board, 3,000 a year, that pay their own trip, that pay to stay on board and help those who are so vulnerable. We had a privilege here. Let me share you that. You have to know that Royal Princess Anne was here, and she was so deeply impressed and shared with us how much he is involved as a patron in our mission. We had Andrea Bocelli, a friend of Mercy Ships, singing here incredible songs. And you are here too. And you are as important as people that sing or the distinguished people that are here behind me. I feel like humbled, Mahariat, if you may say so, but also privileged to welcome a very special person. And that is Dr. Miriam John. She is our International Chief Medical Officer. She's involved in Mercy Ships since 2017. Where are you, Miriam? I think you were a teenager at the time. And you have served in Cameroon, in Guinea, in Senegal as a physician and in a medical capacity building. She's become a dear friend. We're neighbors here on board the ship. And it knows us. By times, if needed, she's the Iron Lady. But she's also enormously dedicated to our mission to bring hope and healing to Africa. May I ask you for the warmest applause possible for Miriam John.
Thank you, Jan. I don't really know what to do after that introduction. That's so wonderful. So as Jan said, my name is Dr. Miriam John, and I am the Interim International Chief Medical Officer for Mercy Ships. I just wanted to welcome you all to this medical day, where we have an opportunity to talk about the real heart of this mission, the parts where we get to be the hands and feet of Jesus, bringing hope and healing, transforming people's lives, but also transforming healthcare systems as well. And also on this day, as International Women's Day, we have got a stellar female clinical leaders representing us here. So we've got Dr. Harriet, we've got Dr. Audrey, and we've got Amy Jones, who said that she's just a nurse. And I just think we should all reflect on that. No nurses are just a nurse, and quite frankly, they are angels. So yeah, I just want to welcome you to this event where we're going to talk more about the real heart of what happens in programs, where we're going, and what our strategy is for what the future of us working and partnering with countries in Africa. So thank you so much. I'm going to hand you over to Nathan Klaus. So Nate is our Director of Clinical Services. He has been with Mercy Ships since 2012. He started serving as an intensive care nurse and then became head of our patient selection team, and then in 2018 became hospital director of the Africa Mercy. And since last year, he's been director of our clinical services as we plan how we're going to have 2 hospital ships so that we can double what we do. So I'll hand you over to Nate.
Thank you, Dr. Miriam, and I would like to add my welcome to you all. It is very exciting to have this day finally come. There's been a lot of preparation for this, and we are delighted that you have chosen to spend your afternoon with us, both here in the auditorium, and I'd like to add my welcome to those who are attending virtually. I am very excited. We have wonderful panelists that I will introduce you to in a moment. But I'd first like to just give you a little bit of a roadmap for where this discussion will go, and just a little bit of housekeeping. So I will introduce the panelists in a moment and then have some topics prepared, but there will be a section of question and answer after this. So as we're going through the discussion, prepare your questions. There will be someone with a microphone that will roam around and give you a chance to share your questions. And that's true for our virtual audience as well. I'll get to read your questions here on the screen. So please be thinking about that. I think without further delay, let's get to the introductions. So I would like to start with Dr. Mark Schreim. Dr. Mark is a head and neck surgeon, researcher, and professor. He is currently the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland. He is a lecturer in global health and social medicine at Harvard Medical School in Boston. He is a co-author on the Lancet Commission on Global Surgery, and he is the author of the recently published book, Solving for Why, A Surgeon's Journey to Discover the Transformative Power of Purpose. Dr. Mark, welcome.
Thank you.
Next, I'd like to introduce Dr. Harriet Verwij. Dr. Harriet is a retired former cardiologist and associate professor at the Leiden University Medical Center here in the Netherlands, where she also served as the deputy of the Department of Heart Disease. She specialized in the diagnosis and pharmacological treatment of women with heart disease. She is a recipient of numerous awards in her field, and in her retirement, she continues to speak on the subject of women and heart disease. Dr. Harriet, wonderful to have you here.
Thank you so much.
Next, we have Dr. Audrey Agbesi. Dr. Audrey is a reconstructive plastic surgeon at the University Hospital in Cotonou, Benin. So she wins the award for coming the longest way to be here. She was Benin's first female reconstructive plastic surgeon. She founded the association VME, which it means Active Itinerant Volunteers for the Well-Being of Populations, which has impacted more than 20,000 people since its founding in 2015. Dr. Audrey, it's wonderful to finally meet you in person. We've known each other for a while, but it's wonderful to have you here.
Thank you.
And next to me, we have Amy Jones, my friend. It's good to see you. Amy is an intensive care unit nurse in the United Kingdom. She's also a Mercy Ships medical capacity building specialist. When she first joined Mercy Ships in 2013, she played a key role in the burgeoning medical capacity building program by initiating, designing, and leading nurse mentoring programs. And we'll talk more about that. Amy, glad to have you here.
Thank you.
Well, so for the content of the discussion, I hope it goes a little bit as planned, but I also hope we take some turns here and there, so please feel free to do that. But I thought we would start with putting things in context. So I take it that most of us have something to do with the medical field, the healthcare field, so we have an idea of the global health space. But Mercy Ships focuses specifically on the surgical space. So I would like to place surgery in the context of global health. And I thought we could do that by starting with some statistics, which I will read one to each of you and just get your thoughts and your reactions on that. So Amy, I'm going to start with you. And this statistic comes out of the Lancet Commission on Global Surgery. And it's this. 5 billion people globally lack access to safe, affordable surgical and anesthesia care when needed. I'll read that one more time. 5 billion people globally lack access to safe, affordable surgical and anesthesia care when needed. And the subtext to that is access is even more scarce in low and middle income countries where 9 out of 10 people cannot access basic surgical care. So there's a lot in that first sentence, and I just wondered if you could unpack that for us.
Yeah, sure. So 5 billion was the number there, and that's a massive number, and it's quite difficult to compute that and to work out why and what that means really in practice. And so access looks different to different people in different contexts in different countries. It might be that people don't actually have the right services in the country where they are. Maybe they don't have a surgeon with those expertise in a country in order to get surgery. And they may have to travel to a different country. Or they may not have a hospital anywhere near them. They might have to travel for a really long time to get to a hospital. And so it might be about geographical location. It might also be about accessing healthcare in terms of finances. People in lower income countries are not necessarily going to have the same kind of finances to be able to fund their healthcare. And so you can imagine that if somebody needs surgery and they don't have the funding, they're going to potentially push themselves, their family, into debt. They may need to borrow the money to get an operation, but also they may end up in debt to the hospital. Equally, somebody might have to wait a long time for surgery while they are finding finances. So I remember looking after a little boy in a pediatric ward in a local hospital who had an open leg fracture, and he was waiting for his father to come back with money for surgery. So he was in the hospital, and he wasn't just waiting a few hours for his father to find money. He was waiting weeks, he was waiting months. And you can imagine what happens to an open leg fracture when you're waiting months. Most of us won't likely see what that looks like. But it's not pretty when you do, and you can imagine the complications for that child are massive. Infection, sepsis, potentially death, because he cannot access that surgery, even though he's in a facility because of the finances. You may have someone who can access the facility, they have a surgeon, they have a hospital nearby, they have money, and they can access it within time, but they might not get access to safe surgery or anesthesia. I've seen a woman on an operating table waiting for her surgery. She's been intubated, ventilated. She has a surgeon, she has the facility, they have the expertise, and she has the money to pay for the operation. But as she's ventilated, there's no monitoring equipment. There's no end-tidal CO2, there's no saturations recorded, because they don't have those particular bits of kit. And obviously totally unsafe. And so the outcome for that woman, even though she has those other things and she can access the care, it might not be safe for her to do so. And she might have a good outcome, she might have a bad outcome. And so as healthcare professionals, we're always trying to make stuff safe. We're always trying to be better and better at what we do. And these healthcare professionals want to do that too, but they don't always have the means or the way to do that. Got one more example, just to put it all in context. In Madagascar, when we were working there, there was a big problem with obstetric fistula, which we'll probably end up talking about a little bit later, so I won't go into what that is. But the government, in order to kind of combat this problem, were giving free cesarean section surgical kits to every woman that was eligible, which is amazing. However, inside the surgical kit, there was no sutures and there were no gloves. Which obviously in my context back home is brilliant, because then the surgeon can choose their gloves, they choose their suture, right? So it's convenient. But in that context, if you are a woman and you're in labor, you could pick up your C-section surgical kit from a pharmacy, amazing, you take it to the hospital, and you can have your surgery. And so you have the access, it's timely, you're in labor, you're about to give birth. You can afford it, it's been funded, it's been given to you, and it's probably safe. But actually for the women that had those kits given to them and they couldn't afford the suture and the gloves, which is a couple of additional dollars, they still don't have access. So those people, the boy with the leg fracture, the woman with the kit, they're in the 5 billion. That's what it looks like to be within that number.
Thank you, Amy. Thanks for painting that picture.
You're welcome.
Yeah. Dr. Audrey, the next one is for you, and it's, in 2010, an estimated 16.9 million lives were lost from conditions needing surgical care. I'll read that one more time. In 2010, an estimated 16.9 million lives were lost from conditions needing surgical care. This figure well surpassed the number of deaths from HIV/AIDS, tuberculosis, and malaria combined. What are your thoughts on that?
Thank you for the question. I think the answer matches with the answer of Amy, because it's the same context. And to give an example, in my country, we have what we call moto taxi. And there are many, every day we have many cases of trauma. And we do not have a system of insurance. So when people come, most of them have open fractures. I'm talking about daily things. You can have more than 20 in just a hospital. But all of them, they cannot be treated like at the time they need it, because of all the problems that Amy already described. Sometimes they have money, the surgeon is available, but we lack maybe infrastructure for anesthetists so that we cannot perform the surgery. Sometimes you do not have the right specialist to perform the surgery, so you cannot access to this surgery. Sometimes you have the specialists, you can afford, you have the facilities, but you do not have access to supplies because the hospital lack the supplies, but you have to buy it, but sometimes you cannot find it in the pharmacist. So I think this totally match with the reality we are facing every day in my hospital.
Thank you, Audrey. Harriet, you're up. Of the 313 million surgical procedures undertaken worldwide each year, only 6% occur in the poorest countries. Yet that is where over a third of the world's population lives. So I'll say that one more time. Of the 313 million surgical procedures undertaken worldwide each year, only 6% occur in the poorest countries. Yet that is where over a third of the world's population lives.
Being a trained medical doctor in Europe, these numbers looks like it is from another planet. You know, we are not familiar with this in Europe or USA. So it is horrific to know that, you know, the basic concept is that health is a human right, and that people don't have access to surgery, while surgical diseases compromise about 1/3 of all the diseases. So they are way behind. And when I read these stories, as I said before, it looks like it's from another planet. So they are the same human beings like you and me, yet they lack what they needed and what is their human right. So I think there is a lot of work to do, and I must say I applaud for Mercy Ships what they are doing, and also not only performing the surgery or making it affordable and available, but also working on the infrastructure in those countries they visit, so that after the ship has left, people can still walk on their own and make sure that the people who live over there, that they can have the same medical treatment as we have in Europe, et cetera, et cetera. And it starts all with prevention, because most of the diseases Mark, for instance, operate on, perform surgery, they are treatable, but moreover preventable. So there's a lot to do, and I definitely am very honored, but most of all, I applaud for Mercy Ship what they do. It's, and I would ask the audience to applaud for Mercy Ships as well. So give Mercy Ships a good round of applause.
Thank you, Harriet. Okay, Mark. This one actually comes from a paper you and your colleagues wrote, published in the British Journal of Surgery, so let's hope you have something to say on this. It's 44% of the world's population couldn't afford surgery if they needed it today. Again, that's 44% of the world's population couldn't afford surgery if they needed it today. What's going on there?
Yeah, thank you. I think we've already started to address this in Dr. Audrey and Amy's answers. There's, you know, this ship and the Africa Mercy do a lot of surgery over the course of a year, but it's a drop in the bucket of the surgery that's needed. As a response to that, we're doing a lot of the training and a lot of the infrastructure development that Harriet has talked about, all of which is important. But on some level, it's important as long as the patient can get there. And at this point, in most countries in the world, more than half of the population, if they needed surgery today, would be, as Amy has said, driven into debt, driven into destitution. Some surgical disease is preventable, and absolutely, but some of it isn't. I can't decide when I'm going to get into a car accident. You know, you can't necessarily decide when you need a C-section. So some surgery is absolutely not plannable, preventable, and then if you need that, if I get into a moto taxi accident and have an open fracture and I'm one of that 44%, that simply means I can't get it through no fault of my own, maybe even through no fault of the system itself. It's just that the health system, I have been priced out of the health system because of the way the health system has developed. And let me just say one other thing, sorry, Nate. It's a problem in the countries in which we work. It's a problem worldwide. I mean, for any Americans in the audience, you know it's a problem in the American healthcare system as well. This idea that health is a human right as long as you can afford it is not the world we really want to be building.
Thanks, Mark. So we're starting to get a picture, I think, of this challenge of lack of access to surgical care. And I think the statistics help, but for some of us, they might go over our head a little bit. So I was hoping with all of the amazing experiences that you all have in your careers and in your professions, that you could help make these statistics a little bit more tangible for us, and how are they borne out in reality. And we've touched on that a little bit here, but I want to dive into that deeper. So I actually want to start with you, Audrey, because I think your story and how you were inspired to become a plastic surgeon is just a tangible example of this lack of access to surgical care. So could you tell us that story?
Okay. I can say that all the story begins when I saw on a TV show a story of a woman whose husband had burned her with acid, and her face had become fused to her neck, and there wasn't a plastic surgeon in Benin to treat her. And then they show her on TV because people were raising funds to send the woman to Europe to be treated. And this story touched me very hard, and it's from there that I thought to myself, I have to become a plastic surgeon to give such a specialist to my country and to make my people have access to this kind of treatment. And everything started there. I went through many challenges, but I thank God I finally realized my dream to become a plastic surgeon in 2015, where I got trained in Morocco for 5 years. In fact, I did my general medicine in my home country, but I couldn't have access to the training in West Africa. So I got the opportunity to go to Morocco and be trained as plastic surgeon. And when I finished in 2015, I came back in my country because it was like a civic duty to become plastic surgeon.
It's really wonderful. Okay, Mark.
I'd say the patient that made me become a surgeon was a patient who was 22 at the time. We were in Monrovia, we were in Liberia, which is let's call Liberia here. Guinea kind of stretches over Liberia like this. The capital of Guinea is over here, where most of the healthcare in Guinea is, but this patient lived all the way over here, lived closer to the capital of Liberia than he would have to the capital of his own country. So we did a screening trip up into far eastern Guinea, found him. We don't have his picture on this, but he had a jaw tumor that had been growing since he was 14. So it really kind of went down to his sternum, went down to the middle of his chest. I'd been training, similar training in the US and training in Canada. We don't see cases like that. So we took him on with Dr. Gary Parker, whose name I'm sure you've heard over the course of your time here. We took this tumor out, and in doing so took his jaw out, except for a little bit of bone left, reconstructed it with a metal plate, let that sit for a few months, then took some bone from his hip, reconstructed his jaw with that bone. And I really would say that's the patient that moved me from being a trainee to being a surgeon.
Mm-hmm. Oh, wonderful. Thank you. Amy, how about you? Any story, experience come to mind that helps give these statistics a tangible kind of presence in our mind?
Yeah, I think the story that comes to me is a story of a girl called Manette, who was 14, and I met her in a local hospital that I was working in at the time. I was running some mentoring sessions for some midwives, and one of the midwives grabbed me and said, "You need to come and see." What she said was, "You need to come and see the poor family. I've got a poor family." This is in the context where everyone's poor. And they took me to this small room and introduced me to this 14-year-old girl who had just made a 4-day journey to the hospital in labor for all 4 days. She was 14 and she was in labour. And she tried to deliver the baby at home in her village, and with no success. So she got on the back of a truck, and her auntie and her uncle drove for 4 days to get to the hospital. And when they got there, they had no money for surgery. And so without a C-section, in an obstructive labour like that, the baby will die, and the woman will probably die, but if they don't die, they'll end up with a vaginal fistula, where you've got a hole between your vagina, sorry, and your bladder, or also it could be rectum, and you eventually would end up incontinent through this hole without surgery to correct it. And Minette was very much in the septic phase of this, so she'd lost the baby, and she was confused. She didn't know her own name. She was malnourished. She was rolling around the bed in so much pain. And the midwife was like, you have to help her. You have to help her. And I knew that we would not be able to help her, because we can only really treat women with this condition who are well, who are fit and well and ready for surgery. You can imagine that's a massive insult on the body to then take them to surgery. It's just not going to work. They need to go through some healing and rehab before they get there. And I remember talking to Michelle White about it. I think at the time I was in your office in tears, because I was like, we have to help this woman. And I knew that she just didn't fit into any of our boxes and Mercy Ships. She didn't fit our protocol. And Michelle and some others were like, well, let's talk about it, see if Dr. Andy Norman, one of our amazing OBF surgeons, will be able to assess her, and maybe we can talk about it, maybe we can discuss it. At the time, and I know you mentioned infrastructure, and that's something we do on Mercy Ships. At the time, we were building a obstetric fistula clinic in Madagascar, in Tamatave, and we had done lots of renovations. We had made this beautiful clinic functional, and we were starting to bring women there to recover after their surgery on board, with the long-term vision of making that a sustainable clinic with an operating theatre and recovery beds, so that women could come there in the future and have their surgery done and go back to their villages, and they would have access to that surgery. And so we were already well on the way to providing that service and then handing it over to local partners when we left. And so we had these discussions, and the surgeon came with me. He assessed Minette, and he left, and he confirmed she had a very extensive obstetric fistula and that she would have to recover for quite some time before we could operate. And so I was thinking totally off the table, and he came back with 2 options. He was like, firstly, there's a lot of girls in her situation in this country, and we can't help everybody. He was like, the second option is that, as Mother Teresa would say, she is the one person in front of us, and she needs us, as Jesus would be, the one person in front of us that needs healing. We need to act. We need to do something. So he gave those 2 options, and I kind of sat there and cried a little bit, and I was like, I like number 2. I really like option number 2. And so we went back to the ship, and we had discussions and talked to the chief medical officer and lots of other different parties, and decided to operate on her. And so she had the first operation with Mercy Ships on board the ship. She then went to recover some more, and she actually came back. She still wasn't completely dry. She was still incontinent at that point, but we managed to fix some of the wound. She then came back in the following years to the clinic in Madagascar that we helped set up, and trained anaesthetists and surgeons and nurses to be in that clinic and run that clinic for like lasting impact in that country. She came back for her next surgery in that clinic and is now completely dry. And it just paints just a really great picture of how something that seems totally impossible actually can be possible when everyone comes together, but also just how building the infrastructure in a country and working with local partners can have a really lasting impact in that nation.
Thank you, Amy.
Welcome.
This is a little bit of a pivot, but I'm started just noticing the photos behind us and in front of me here, and so I thought I would ask this question because I think it's part of the Global Mercy experience as well, these images, and I remember when I was new to Mercy Ships, these shocked me, and I had never seen pathology quite like this, and certainly not as severe as this. So I think the question is, what's going on here? Is this something unique to the part of the world that Mercy Ships works in, or is there something else going on? And I thought, Mark, that you would be a good person to answer that question, and due to the fact that you've worked in many settings all over the world. So what's going on?
Yeah, so that's a great question. There are always slight variations in disease prevalence across countries due to genetics, due to environment. But I don't think that's enough to explain what you're seeing here. Most of the tumors that we take out, I do the tumor surgeries, or some of the tumor surgeries. Most of the tumors that we take out are exactly the same pathology as I would see in my clinic in the US or a clinic in Europe. It's not like these tumors are some bizarre, strange disease that we've never seen. The woman whose face keeps coming up with a really large tumor on the right side of her face, that is for the any ENTs in here, that's a pleomorphic adenoma. That is the most common tumor of that part of the body. What makes it so dramatic is not that it's a pleomorphic adenoma. What makes it so dramatic is that if I noticed a lump in my parotid gland, I would be in the doctor's office that week. She noticed a lump, and it took 25 years for her to be able to be seen by somebody who would then be able to do the operation for her. So it's not like, it's not like she didn't notice that there was a tumor growing there. It's not like there was anything special happening about her or about the disease. It is all, it's the repetition here, it's all this lack of access. The size of that tumor is due to the fact that, as the late Paul Farmer used to say, the staff, the stuff, the space, and the systems for surgery don't exist in the countries in which we work.
Yeah, so we've talked about this, these are really symptoms of lack of access, but I wondered if we could just have a little bit of a discussion of the consequences of this delay in care. So, and we're talking not days or weeks of delay, we're talking months and years. I think most of the patients that we see on board we're talking in the timeline of years, if not decades. So what are the other consequences? Certainly, I would imagine, I'm looking at the surgeons here, that it makes surgery more difficult, but there are other consequences to this delay in care, I imagine. So this is for anyone to start having you all talk to each other instead of just to me.
Okay, of course, there are consequences because there are some disease, if they are not treated early, they can spread elsewhere in the body, and it becomes difficult to heal the patient. Even though you can operate and treat the patient, you are not sure that you will be able to heal the patient. So, and what I wanted to add on comment of Dr. Nathan is sometimes is also a cultural thought, because when the tumor or when the pathology occurs, sometimes people think is like a spiritual things. They don't look for treatment, and maybe thanks to I don't know how you call it in English. Sorry, when you organize a campaign to explain to people that there are some disease, now they are aware, awareness campaign. Okay, well, now they are aware that it is a disease that can be treated. So it's the same about cleft lip and palate and some other disease. But for sure, there are some disease that if they delay in the treatment, it becomes difficult to give the right treatment and to heal the people. So it's one of the consequences. And this can sometimes lead to the death of the patient.
But in general, it's not only the lack of of access to medical treatment. Like you said, it's cultural belief sometimes. And the bigger the tumor is, the more complications you might run in after the patient has surgery. But also, I think it's lack of knowledge. I'm very an advocate for telling people, so the campaign is one of the things, that what you have, it doesn't belong to you. You need to be healthy, so get rid of it. And you know, that is something you come across not only in Africa, of course you see it there in a massive way, but also in other countries. For instance, women and heart disease was something for until 10 years ago, we lacked the knowledge about how to treat women with heart disease. So when now the knowledge is available, the doctors know how, but also the women are aware of to just go and get their treatment, what they needed. So it's multifactorial, and I think that's why I would still go for preventive care. Make sure there's a primary care service, that they teach the patient, that they train other caretakers, etc. Because by doing such, if you can avoid some complications, you can avoid disease, prevent disease, and when disease happens, you can treat it with greater positive results. So it's very important. It's knowledge, make it available to all, and especially I go for tell women, that give them the knowledge and tell them, let them be the role model in their community. It goes faster when you tell a woman what is healthy.
Please, can I add something?
Of course.
Yeah. It's so much important about awareness and knowledge about the disease people have. If I take the example of cleft lip and palate, when I graduated and I come back in the country, I thought the people don't suffer from cleft lip and palate because we do not see too much patients. But when we started making awareness campaign, we realized that most of the kids, sometimes they are killed. Because for the parents, it's a curse, it's not a good thing, and they are not aware that they can be treated. And to hide the baby, sometimes they is going to kill the baby. So it's kind of pointing the importance of knowledge and awareness campaign so that people can be aware that they can be treated and the treatment is available around them. That is something important, I think.
Absolutely.
Can I jump in?
Sure.
One of the things that Dr. Parker says often is that surgical disease does more than we're all sort of in the health environment, so we look at these pictures as health issues, and they are. But what surgical disease, these bowed legs, the cleft lip, the tumors, the obstetric fistulas, what they do is they rob patients of their seat at the table of humanity. Sometimes it's because the children are killed, and even if they aren't, they're ostracized, they're hidden. If I'm a shop owner and I have a large tumor growing off my face and the shop owner next to me doesn't, very likely they're going to get more of the business than I am. So I'm no longer, I'm robbed of a seat at the table of humanity, robbed of sort of the ability to be part of a sort of economically viable part of my country. We're doing surgery here. We're fixing these visible things. And it's not just to fix the visible things. It is to hopefully allow patients access back to their communities.
Wonderful. Yeah, I picked up on that. There's certainly a social consequence. There's a community consequence. There's a knock-on economic consequence to this as well.
That reminds me too. Oh, sorry. That reminds me too. Just talking about obstetric fistula, and I was saying with, if you can treat it early, like once the patient has recovered, and you complete the surgery for that woman quickly, not much in their life will change. But if a woman lives with obstetric fistula, and you can imagine if you're incontinent continually, in a lot of rural communities in West Africa, the women would be cast out of their village, They wouldn't be able to work. Their husbands would leave them. They would be pushed to the fringe of society. And an obstetric fistula surgery maybe cost £200 to £400 or something like that, dollars maybe, and takes maybe 30 minutes if it's a simple one. But you can imagine the life, to restore that woman's life, if she's lived like that for 40 years, will take a hell of a lot more than that amount of money and that amount of time to restore. So again, it's about those consequences of not having action.
Audrey, did you want to?
Yeah. Okay, talking about the consequences, I remember a story of a baby. She was born with bilateral cleft lip and palate. And because the mother gave birth to such a newborn, she couldn't go back to her home. And the husband rents another place for her to stay because he thought he cannot bring this back home in his family. But the woman have other 3 kids. But because of that, she couldn't access the other kids since he gave birth to this. And he also left her husband. So she was living alone with the newborn, giving time to her husband to think about what to do. I thank God she got the information that the baby can be treated in our hospital, and that is free because there is a program now since 2019. But she did not tell us anything. But the moment we finished operating the baby and she saw her baby, she just started crying. And we couldn't understand. For us, it's a good thing that the baby were able to be operated. And it's at that moment that she told us that since 6 months, she couldn't see her other kids. And now he got the opportunity to go back to her home with her kids and to restart a normal life. Because she left everything, even her activity, her economical activity, she has to leave all to stay until the husband finds a solution for this baby. So it's kind of picture to show how surgery can transform and impact life, not just for the one who benefits for the surgery, but a whole family and a whole community.
Wonderful. Well, wonderful. Thank you all for those experiences. I think that is valuable, and it's really painted the picture of this lack of access and the need and the consequences from the lack of access. I want to transition now to what can be some of our responses to these challenges, and just get your thoughts on that. And I'd actually, because this is a Mercy Ships event, I thought we would share the ways that Mercy Ships is responding to that need and to those challenges of lack of access. And Amy, you are the one that I think has served the longest on board, so I'm going to ask you to just give a kind of high-level overview of the way that Mercy Ships responds and kind of a high-level overview of our programmatic menu of options.
Sure. So you guys will have been on the tour and will have seen lots of information downstairs, which is great, and those visual kind of pictures. The experience thing with the headset is so cool. Did you guys really enjoy that? I loved it. So you've kind of seen a little bit about what we do, and we've talked about it a bit here too. But essentially, we kind of have our surgical side where we are running programs in orthopedics, general, maxillofacial, as you've heard about, plastics and women health, and eyes. We have an eye program as well. And if there's any of you in the room that have specific questions about some specific things, if you have those skills or talents, then please let us know. We've got some time, I believe, for networking. Yeah? Great. So please come and ask questions. We can hook you up with the right people. So that's kind of our surgical, immediate, stand in the gap for the people that need surgery and can't access surgery. Then we have our other kind of side, which is the non-surgical side. We've got dental. We set up dental clinics. We did a lot of extractions in a lot of different countries. There's a lot of teeth. We've got a palliative care team, which is something maybe you don't necessarily picture or think about so much, but it's been a great reassurance to me before when I've been working in local hospitals and you meet people that actually just need really good palliative care. And we have a team that we can refer them to so that they can get pain relief and emotional support. And we have a hospital chaplaincy team, which you've probably seen a little bit about downstairs as well. I know Clementine was on some of the videos and the audio for that, who come alongside our patients and really support them emotionally, which is amazing to have. And then we've got, I'm probably missing things out because there's so much that we do, but then we have all of our training and our medical capacity building. So we've got mentoring, where we come alongside and walk with surgeons, nurses, anaesthetists, physiotherapy sometimes as well, and different things. Depending on the country we're in and depending what the need is, it shifts and it changes. And so we walk alongside them, we see where they work, what kind of education, what kind of needs they have, what's appropriate and relevant for them. And then we also run courses in safe anesthesia, safe surgery, essential surgical skills, Ponseti. The list is endless. Yeah, there's so much. I'm missing things.
That's all right.
But each country we go to, there are discussions about what that country needs, and what is appropriate for them, what's relevant for them, where are their gaps in the care that they're providing, so that it's specific for them. Yeah, but if there's specific things that you want to know more about, then I'd urge you to we can connect you up.
Wonderful. Thank you, Amy.
You're welcome.
One of the things that Amy mentioned was the medical capacity building, so the medical education and training and mentoring. And so Dr. Audrey, I want to ask you a little bit about your experience with that. You shared earlier about your time, your first time on board mentoring together with Dr. Tertius, but I think that one of the cool parts about your story is that you've been on both sides of the training thing. So you've been a participant, but then at some point you transitioned and now you deliver training as well. So could you talk about the inspiration for that transition to go to becoming one that delivers the training?
Got this picture. Okay, thank you. Before you missed the Food for Life program.
Thank you. I missed a few things, and the infant feeding program.
Just to say that it's not just about surgery and healthcare, but is about the holistic aspect of health. Okay, coming to my question, to the question to me about medical capacity building, I think the thing I love with the model that Mercyship design is that they train and they also train people to become a trainer, so that even the ship left, we can keep on training and making more lasting the impact that Mercyship leave. So I have the opportunity to be trained on essential surgical skills and essential pain management. And I was able to share this knowledge with my colleagues back home, so that even for those who did not get the opportunity to go on board and have the training, they can also access the same training that we have gone through. And I thank Mercyship and his team that give me also the opportunity to go and share this knowledge with my colleague around across Africa. The good thing is also that I'm working in National Teaching Hospital, and in my department, we have some medical doctor coming for specialization in orthopedic surgery. So I get also the opportunity to train them about some skills in plastic surgery, so that when they perform their specialization, they can be able to perform some plastic surgery as well. So that is what I learned and liked from Mercyship.
It's that lasting impact, that train the trainer model for the lasting impact and for the multiplication effect. It's really wonderful.
I can say also that in my hospital now, we have more trainer, and now they can help train other as well. And each year when we have the new students, like I cannot say student, the new medical doctor starting their specialization, we have more trainer to train them about the workshop we went through with Mercyship, so that they have the same before they continue their specialization.
Harriet, while we're on the topic of education and sharing knowledge, did you have any more thoughts about that? I know that you're passionate about that.
Yes, because the way to victory is through knowledge, and when I did a tour on last Monday, I saw this as well. What you were mentioning, the Food for Life, because it's very important to share knowledge and to train people and to have them trained by people who look like them. You know, then it comes when I go to a place where there are a lot of other types of people. There, of course, we are all human beings. But when I say I have experienced this so and so, it will more easily be grabbed by those who look like me. So it's very important that Mercyships train the locals, especially on growing foods, fruits and vegetables, etc. Because you see, many of those diseases which you come across, many of them have a nutritional deficiency as an underlying cause. That is not apart from lack of knowledge, etc. The people are in a bad nutritional state. So when you teach them to how that healthy food is delicious as well, because many people go like a kid, nah, that can't be easy, can't be nice, but it is. So when you train them, I think kinds of diseases will be preventable. And you other, of course, behavioral risk factors like tobacco smoke and so forth, and so on and so on. So knowledge is I think the mainstay for longevity, not for the moment. The moment you have to perform surgery, but for sustainability and longevity, you need knowledge. And I was very much impressed by what Mercyships is doing now to teach them how to take care. You mentioned a place at the table, but it's not only just to sit at the table, you have to remain at the table. And then comes all the others. Otherwise, it's a one-stop shop, and that's not what you're not aiming for. So I like this whole holistic program Mercyships has now on the stage, on platform, to make it sustainable what they are doing. And that is really a great thing to do. Yes.
Wonderful. Mark, I have a question for you about sustainability, actually. So let's see how I can frame this question.
Boy.
So we love in Mercyships that our medical capacity building programs are growing and growing. It's really kind of infiltrating every part of what we do, which is absolutely incredible. Should we stop doing the direct surgical care and focus on that? You mentioned, I'm going to pick on you again, because you mentioned this concept of a drop in the bucket of 5 billion. Is it really a drop in the bucket, or is there still something to be done with direct surgical care?
This is the problem when the moderator is a friend of yours. Actually, I'm going to go back to the image that Amy brought up. It's an image that if you all have read Don Stevens' book, it's at the very beginning of the image. He tells the parable of the starfish. He calls it. A boy is walking along a beach littered with starfish and is throwing one starfish back into the ocean over and over again. And an older man comes up to him and says, "What are you doing? There are all these starfish. You're never going to fix this. Doesn't matter." And he says, "But it matters to the starfish." So should we stop doing direct medical care? No. the sustainability is all the stuff that we've been talking about here, the training, the education, the nutrition, all that stuff. That's what will change things. In the interim, you've still got the patients that you've been seeing on the screen that haven't had access to surgery for 25 years. And so there is, and this is less so now, but in the global health conversation, there's this tension between relief and development. You must be doing development, or no, you must be doing relief. Kind of got to do both. And that's part of what Mercy Ships is doing here.
Mm-hmm. Okay, I'm going to linger on this a little bit because I want to tease the professor out in you and ask you to explain what a disability-adjusted life year is.
Gosh. All right. Diseases do two things to us. They kill us early, which is a pretty easy thing to document. If I have a lung cancer, I can tell, I can estimate how early compared to not having a lung cancer I would die, and I've lost X number of years of life. But they also make us live when we have the disease at something less than perfect health. So a cleft lip and palate is a really good example, or an obstetric fistula is a really good example. There is a little bit of early mortality with cleft palate. Patients with untreated cleft palates do die slightly earlier than those without, but the big effect of the cleft lip and palate is that for your entire life, if it's untreated, you're living with a cleft lip and palate and all the stuff that goes along with it. What a disability-adjusted life year does is it combines both of those. It measures how far away from perfect health you are by combining how early you die and how much time you're living in less than perfect health. I'm very curious where you want to go with this.
Well, I wanted to go on the sustainability of direct surgical care, because if you're restoring health to somebody, you're restoring their economic capabilities and their social capabilities. Is that right?
Yeah. So we've done some research on this actually here on Mercy Ships. It's not published yet, but we have a paper where we examined our maxillofacial department over the course of a year, all the patients that came to the maxillofacial department. We examined what happened to their health, and it's going to be no surprise that their health got better after surgery. That's great. It would be really bad if it didn't get better after surgery. So we found that their health improved. But we also found that over the course of a year, their incomes improved after the surgery. Disability-adjusted life years were restored to patients. But if you dig into their descriptions of their health, the domain of their health that they found the most improvement in wasn't things like pain or anxiety or anything like that. The domain of health that improved the most was re-engagement with community. That was the one domain that actually improved with the surgery.
Thanks, Mark. Gold star.
Thank you.
Okay, I want to talk about one more thing in this section, and just really about the country engagement model of Mercy Ships and the partnership with the host nation. And let's see, I think I want to ask you about that, Amy, and just give us a brief overview of how does Mercy Ships engage with the host nation, with the Ministry of Health?
Sure. So we generally are invited, first of all, that's an important point, by countries to start a conversation. And we kind of, there's a lot of chatter and a lot of whining and dining, I believe, that happens at that stage that I'm not party to. So we'll miss that section out. But once we know that we're going to go to a country, we will go in and assess. And there's a big assessment phase where we look at, with the Ministry of Health, with lots of other different partners and hospitals and all different things, what is needed in that country? What do the government feel the needs are? And then we start, as we go along, assessing what individual hospitals feel the needs are for their staff and for their healthcare system. And so that's assessment. We then deploy the ship, and we have normally a 10-month field service in each country that we go to. Sometimes it's been longer in the past, sometimes shorter, but generally around 10 months is a good time for us to complete surgeries and allow time for recovery. And then during that time, we'll do lots of training, teaching, mentoring courses, and some infrastructure projects as well. And then afterwards, we would go back and spend time evaluating how everything went. We can also, as we send teams back to see how the staff are doing after their training, whether they're implementing things, whether what we did actually impacted what we wanted it to, we really want to see that we're evaluating what we've done and what the impact was, and if we can support those staff members and those hospitals any more as well, and what they need in the future, and how we can continue to support them.
Wonderful.
Can I ask you, Amy, you said we are invited. By whom?
By the country.
By the country. But could it be that an NGO discovers the enormous problem the country is facing and the government don't want you into? How you cope with that?
Maybe, I don't know. I'm not, I mean, that's above my station, I don't know.
Okay.
But there's, you know,
it
they
could
start
be
conversations.
that sometimes they don't want to have it public what the gap they are facing.
Yeah.
While you know that the people are suffering.
Yeah, true.
Of course, you cannot run into the country without.
No.
But I imagine it sometimes it will happen.
Yeah.
Who knows? Maybe
Who knows? There are
Dr.
people.
The
There are people
doctor
that know.
over there who knows the answer. What happens when you are not invited by the government while there's such a need? The mic is not on.
Now the panelist don't ask a question.
This is probably a question for the...
Wonderful. I can hear myself now. So we only go where the government invites us. We have diplomatic agreements with the countries that we work with. So Dr. Mpele in the Africa office works with ministries of health to come up with an accord de siège, which is essentially an agreement in principle that we'll work with them. But then whatever we do with a country is sort of negotiated with the Ministry of Health. So we have a protocol that outlines what we will do for them and then what they will do for us in order for us to be able to work effectively. So even if an NGO invited us in, if we cannot form a working relationship with that country, we're never really going to engage and create sustainable change, because if the government doesn't want us there, we can't work with the system that already exists to help improve things for the healthcare workers and ultimately the patients that we want to serve.
Yeah.
Thank you, Miriam. Appreciate you jumping in there.
There's a question over there.
Well, we're almost to the question and answer section. We have one more to go, and then we'll open it up here. I'm sorry, I didn't hear that.
He'd like to answer the...
Just a moment.
Just a moment, we're getting a microphone over to you so the virtual audience can hear you as well.
Okay, I'm Tektan, I'm a plastic surgeon in the Netherlands. With your question about the problem with the government, I've working for 20 years already in Indonesia for this kind of work. It's a very important question because we have a team here from Rotterdam going to North Sumatra. In the beginning, it was problem with the government, not only the government, but the local doctor, medical doctor. It's important you have agreement, collaboration with the government and the local doctor, because that is their territorium.
Mm-hmm.
Yeah, this is the same as in the Netherlands. If a medical doctor from the USA coming here for operation, all the Dutch medical doctors say, "What are you doing here in my territorium?" Yeah, it's very important to do that first, because otherwise you have problem. All the local police, local army, they are working against you, and also the local people.
Yeah, absolutely. I think the key there is partnership and really partnership with the Ministry of Health, and it's really an accompaniment and a solidarity thing. We're coming alongside the surgical system. We augment it in certain ways, but it's really a partnership to strengthen the health system together. So thank you for your comments.
Can
The
I-
last section here I wanted to get to because we're running out of time here, and I want to leave some opportunity for questions from the audience. In full disclosure, this section I really want to be inspiring because we have medical professionals in the audience and on the internet, and we need partners and we need volunteers, and this work is not sustainable without many, many of us. So that's your challenge, panelists, to be inspiring here. So I think I'll start with you, Harriet. We asked each of you to give us a quote that's meaningful to you, and I'm going to read yours, and I would like you to just expand on it and why you chose that quote. So this comes from, I understand, outside of the lecture hall at Leiden University Medical Center, and it says, "Never let your help render a person powerless to help himself, but support him by your strength so that he himself will be able to weather storms."
Yes, this is a very important quote to me. I've seen it as a student, and every day as a medical professional I walk by, and it inspires me not just to help someone to get control, to get his life back. I would used to say to my patients, you are the president of your life, you are the president of your body, and act like that. So to give them health, to give them strength, but also to give them the tools and the opportunity to stay on board and to be the one who rules their own life. So it's very important, and it aligns very much with what Mercyship is doing, the infrastructure. You not only perform surgery, restore life and hope to people, but also you equip them to continue to be the boss of their own life. And that, I think that is plus is relief, plus you make them boss over their own body. So that's very important.
Make them boss. I like that. Okay, Dr. Audrey, the quote you chose is from U.S. President John F. Kennedy, which is, "Ask not what your country can do for you, ask what you can do for your country." Why did you choose that one?
I chose this quote because I think when you are born somewhere, means that you have a mission. And for me, you cannot wait every time for people to do things for you. You have to give your part, to do your part, to make also people profit or benefit from the gift that God put in you. So you have to do something for your home country, for your continent, not just stay and asking, why don't my country don't do this to me? Why don't I'm not able to get this? But ask yourself what you can give. And I think I choose this quote because I think it's also matched with Mercyship vision. Because if people are volunteering, it's kind of donating what they have inside them to other people. So it's why I choose this quote, and it's my favorite quote. I work with it.
Thank you.
Thank you.
Amy, you chose a quote from Nelson Mandela. "Education is the most powerful weapon which you can use to change the world."
I did. I received that quote on a badge from Kirsty Randall once. She was here a second ago. The lovely human that is Kirsty Randall. I was working in medical capacity building, and sometimes it's a bit dry and you don't see very much joy and change. You can imagine if you're healthcare professionals, you tell somebody to change their practice in any country, in any setting, there's reluctance. And so sometimes it would be tricky. And I remember that quote, and after seeing so much apathy where I was working and not very much change, I remember it just reminds me of going to do an evaluation in Congo, and some midwives had just had some neonatal resuscitation training 3 months before that. And we went in and we had very low expectations. And when we got there and we asked how they were doing and if they had implemented the neonatal resuscitation program in their practice, they said, yeah, of course we have. Look, that kid down there, they were dead and now they're alive because we used the resuscitation model. We used the ambubag and now they're breathing. And they just, what I noticed in that moment was, like talking about education as a weapon, they, before that information, when the baby came up blue and floppy, there was nothing they had. There was nowhere else they could go with that because they didn't have the knowledge. And after the training, they stood up taller. They had something they could use that was powerful. And it is like a weapon. And if you give a Congolese mama a weapon like that, like there is no stopping them. Those women are hard. Like they are strong women. And so just to see them stand taller and to know that they had something they could use in their practice to save lives was just incredible. So it just always reminds me. Weapon.
Thank you. Mark, I'm switching it up here a little bit. Not going to read your quote.
Okay.
I want to talk about your book a little bit. So you just had a book published earlier this year. Again, it's called Solving for Why, A Surgeon's Journey to Discover the Transformative Power of Purpose. Sorry for the broad question, but why did you write this book?
Yeah, I'll try to keep this brief. I never wanted to be a doctor. I spent 15 years of training and post-secondary education kind of pursuing something that I did not want to do. I did it because I'm a child of an immigrant family, and children of immigrant families become doctors or lawyers or failures, so I chose doctor. Genuinely, it's hard to sort of get across in a couple of seconds how many times and how hard I tried to quit medicine. 2008, when I first came to the ship, I'd been training to do these head and neck tumor cases, it was the first time I was on the Africa Mercy that I walked into the tumor ward and I saw these patients that you've been seeing on the screen here, and I had very much a road to Damascus moment, very much a, oh my God, this is what I've been training for 15 years to do, and I didn't even know it. Now, I am not a brave man, so it took me, I went back to my training, got a job as a physician, even though I knew I didn't want to do it, got a job as a physician in a big city in the US, and kind of continued on the road that I had been on, and spent a decade kind of elevating the path that I was already on above the purpose that I knew I wanted to be fulfilling. And my whole point in writing this book is to encourage myself and others to write that hierarchy, that the purpose that you're on is what the path leads to. It's not that you discard parts of the purpose so you can stay on the path that you're on. It's that if these two don't match, then you discard the path in pursuit of the purpose.
Well said. Thank you.
Thank you.
Okay, well, I think we will open it up now to a question and answer section. So you have 4 experts in front of you and varied experience, and so please ask away. I think there will be people coming around with microphones. I think just raise your hand. I think those of you with us online, I think it's coming through the chat, and they're going to put it to me here on the screen, so I will try to pitch it to one of our panelists. Okay, while we're waiting, while the microphone's coming to you, sir, I'm going to start with one from the virtual audience, and I will do, this will go to you, Mark. Sorry, you're talking a lot here, but it's, what will you do when a person can't have a curative operation? What happens when the cancer is metastasized?
This is a really good question, and it's a question we see less often than you might think. One of the problems with a lack of access is that, to a large degree, malignant tumors, malignant disease doesn't last 30 years for somebody to come see a surgeon. I hate to be morbid about this, but to a large degree, the cancers will kill the patients sooner than they can see us. So we don't see this as often as you might think. when we do see tumors that are untreatable on the ship that are not surgical candidates, as Amy has already mentioned, we've got a palliative care team. So it isn't, sorry, we can't treat you, good luck. It is, sorry, we can't treat you surgically, but we will take care of the pain and the spiritual and emotional needs as much as we can.
Great, thanks. I think someone is ready here.
Yeah, my question is about, you obviously arrive in these countries with this fantastic ship, which is delivering, state-of-the-art kind of care. But are there some things that, when you're working on the ship, you are still saying, I desperately need that, and I'm really struggling to get access to that, whether it's more people, more volunteer, is it specific medicines, is there something that you really feel I'm lacking constantly, and I wish I had?
How about you, Amy?
I think that because our surgeries are quite specific, we prepare really well for them. And so we have container ships that bring out all of our stock, everything we need, the surgical packs and everything. And it's kind of a smooth operation. We kind of know what we need, but obviously there are always hiccups along the way. I remember once when we ran out of NG feeds, nasogastric feeds that we would give our patients that can't eat and drink. And me and a couple of nurses set up like a conveyor belt of making them in the crew galley with peanut butter and milk and other things. We'd have to make these feeds for them, and then we have a dietitian on board that would kind of help us work out what to give them. So there's always things that maybe don't come in a container ship, or we run out of quickly because we didn't realize how many we would need for that field service. So there's things that come and go that we would need access to, but most of the time the crew are incredibly resourceful. And so it kind of, there's always little dramas, but we work it out, I think, for the most part.
I think I'll take off my moderator hat for a moment and speak just as someone from Mercy Ships here. And you're right, Amy, I don't think we struggle, fortunately, with physical resources very much. We have wonderful partnerships and sponsors. We do need volunteers. So to directly address that, we welcome volunteers. We have very critical needs in our hospitals right now, from nurse leaders to biomedical technicians, to quality managers, to informatics. We have needs all over our ships elsewhere in the other domains as well. So please, if you're interested, speak to one of us afterwards. I think there will be response cards on your tables, and spread the word. Yes, Bryce, okay.
Oh, hi there. I was just wondering, you referenced, obviously with your capacity building, you also referenced the Lancet Commission. And I wondered if you'd find the countries you're going to are using NSOPs, the National Surgical Obstetric and Anaesthetic Plans, and whether when you're coming to the country, you're feeding your capacity building into their NSOP, or whether you've not found there's been much uptake of NSOPs in the countries you've been to since you started capacity building.
Mark or Audrey?
Yeah, do you want to start, Audrey?
I think I'll talk about my country.
Sure.
And Mercy Ship is involved with our government to implement to implement the NSOP in my country. So all the medical capacity building can fit with the NSOP of Benin. I don't know if it's answered the question.
I mean, I don't have much to add to that. Some of the countries that we're in have implemented NSOPs. NSOPs, National Surgical Obstetric and Anesthetic Plans. One of the recommendations from the Lancet Commission for improving the systems side of space, staff, stuff, and systems is that if countries' health policies don't include surgery, then nothing's going to actually improve. So the idea is to have that front and center in the health conversation. Some of the countries do have them, some of them don't. Some of them have developed NSOPs over the course of our engagement with them. Madagascar was one of those. So as much as we can, we do try to align with the NSOP, and we also, it's not a huge part of our role, but as any organization that works in the global surgery space, part of what we do is advocate for the surgical patient, and part of that advocacy is towards national surgical plans in the countries we work.
I hope you're okay with this, Michelle White. But could I, if that question wasn't fully answered to your satisfaction, I just want to point out Michelle White, who can also, afterwards, you can chat with her. So, who's next? Did I miss somebody?
Bryce.
Oh, yes.
I'm allowed to ask a question,
I'd
Nathan?
say it's allowed.
Yeah, sorry.
Yeah.
Sorry. You were painting the picture, the total picture. You were painting the impact on patients, on communities, what Mercyship is doing. But how was it impacting your life? Spiritual, personally, your community, your environment.
Me. You're asking the moderator?
No. You can pick up one of them. But how was it changing your life? How was it impacting yourself?
Audrey, do you want to take that one?
I think while I was talking, I already talked about the impact Mercyship have in my own life. The first hand is Mercyship is part of, don't know how to say it, but like the skills I'm using in my daily practice now, Mercyship is part of giving me or shaping this skill in me. The second thing is the way I treat now my patient. I'm not talking about the care, the physical care I give to them, but I'm talking about the relationship I have now with my patient. It's not the same, because what I've experienced on board Mercyship is the way they take care of patients. So this also transforms the way I take care now of my patients. I'm talking about treating the patient and at the same time showing love to them. And I think this is the most important thing. And sometimes, even if you cannot heal the patient, the way you behave with him is kind of healing you are giving to him. And the third part is what Mercyship did in my life is also part of sharing vision. Like, you have been given and you have to give. And I think it's this we can see in the model of making a restitution of what you have been taught to others. So if I decided to count how my experience with Mercyship transformed my life, I'll just ask people to look at me when I'm walking, and then they can see how Mercyship transformed my life. Thank you.
Thank you, Audrey. Let's see, any others?
So she's whispering what I was actually going to ask. Thank you. I'm deeply shocked. I thought I knew already something, but I'm struck by your story. Thank you for your time. I have a question for Dr. Harriet. You already talked, both of you, about campaigning and about teaching women. It's a powerful weapon. Dr. Harriet, you told me a couple of days ago that we should teach the women, especially the women on this International Women's Day. Can you tell me why?
Well, women are peacemakers, life givers, the entrepreneurs, and they are taking care in their community. So I think when you teach a woman how to create peace, how to make sure that their offsprings are in good health, and also their husband, of course, and they will spread the news to the community. and they becoming a role model as an entrepreneur, as somebody who has knowledge, and women in general share knowledge. So the news will be spread around the community, and it will go from one place to the other place. So knowledge is a strong weapon. Women are the vehicle just to transport the knowledge. And by doing so, there is also there are papers about that. The difference when you teach a woman versus when you teach a man, what happens? Women, they go fast. And that's not a joke. I love the guys. Don't misunderstand me. But I have 6 brothers. But it goes fast because, they talk about, they share what they have gained. And so it is easily spread around. But they are the life givers. They are the peacemakers. They even in countries around Africa, and they're facing a lot of diseases and morbidity and mortality risk, the women, because most of the women die due to communicable diseases. Nevertheless, while they are in their community, they share, they teach their daughters, they teach their sons, etc., etc. So women are very, very strong vehicle to pass on the news. So I go for women and second for the men.
I think we'll do one more question here. We're running.
Can I ask one thing, Nathan? I've read a document from the World Bank, and it stated that before the pandemic, 500 million people were in poverty or pushed to the edge of poverty. And they expect it to become more than 1 billion in the next coming months. How will that impact the work Mercy Ships is doing? Because you're reaching the poorest of the poor. You have an idea?
I mean, listen, I'd say, it's just going to make the problem that we've been talking about here for the last hour worse. Fundamentally, I believe, at least, that this question of surgery, I happen to be a surgeon, I like to do surgery, but the question that we're talking about here is a question of inequity and injustice. And that's fundamentally what we're trying to work on here. And if 500 million in poverty turns into 1 billion in poverty, that's just going to deepen the inequity and the injustice.
Okay, thank you. Okay, final question.
Yeah, I have a little disruptive question. What about the non-surgical boat for oncology, nephrology, infectious disease? I mean, we are stuck in surgery, but I mean, we have to consider a new boat that would take care of that. What do you think about that?
Everyone, look up. Is it me?
Anyone.
It's anyone, yeah.
Okay.
The only thing I would add, that I would say is that those some of the issues you mentioned there are long-standing issues. They are not something that you can quickly fix with surgery. And so wouldn't it be better, I'm going to ask you a question back, wouldn't it be better to train the people in that nation on those things and give them better resources and develop their infrastructure to deal with those problems rather than a ship coming for 10 months? Because what can you do for those problems in 10 months? I don't know, that's just...
But don't forget, oncology, nephrology problems, they develop from easily treatable risk factors. For instance, the people are not treated for their hypertension, their high blood pressure. So they run into some problems, and also when they discover a lump or something else, when they stay too long at home, you will enter in the palliative care. But if they come on earlier, it is easily treatable. But most of these non-communicable diseases can be prevented by knowledge and primary care. So you don't need a second boat. You need the people on the land, on the country, just to teach them and to train them.
One other thing to that. Health is huge, right? So many things impact health. anything from my eyeglasses to the curb cutouts for wheelchairs on sidewalks. Everything impacts on our health. At some point, we have to decide, what are we doing? What part are we playing in this? And right now, the part that we've chosen is to deal with surgical disease, which is not to say that the non-surgical disease isn't important. It's just that our specialization has been in surgical disease.
Okay.
Thank you.
To add on that, as Dr. Mack said, there is so much to do. There is so much lack. But you cannot also do everything at the same time. And when we talk about surgery, I can count surgery amongst the neglected disease. Like, it's those diseases that people don't show quickly their impact. When we are talking about infections, like HIV, malaria, it's like a communicable disease, and people are aware that if one gets it, the other one can get it, and they are afraid. So most of the time in the countries, there are some funds for that. There are many awareness campaigns to prevent, but when it comes to surgery, most of the time is like, it's just the problem of the patient. So for me, by choosing surgery is like to choose one of neglected disease in the world, and especially a neglected condition in Africa. So,
Thank you. Thank you for your responses. Well, we are coming to a close here, so I think I just want to extend my thank you to you all for joining us today, and my encouragement is, you see the critical needs behind us, and my encouragement is to come on board and join us. We need your partnership and your support, and if I were to answer your question, Bert, why do I do what I do? I've been serving with Mercy Ships for 10 years. I live in a small cabin on board. I live away from my family and friends, but I never thought of it as a sacrifice. This is a place that I've found purpose and meaning in the work, in the community, the rich community life on board, and the adventure that is possible here. And it's truly an adventure. There's people from all over the world coming and going all the time, meeting friends from all continents. This is a rich place, and it's a fantastic place to be a part of. So please come and join us is my request and my encouragement. With that, again, thank you for joining us. Thank you for joining us online, and I will invite Dr. Miriam John to come up for some closing thoughts. Miriam, I'm very sorry. I'm gonna jump in real quick here. I also just wanted to thank all those that helped organize this event. So Sam, Claudie, Danielle, Andrea, if you're watching, Tim and your team, thank you very much. Lots of work went into this, so thank you, and thank you to the panelists for joining us. Over to you.
So yeah, I just want to extend my thanks as well for you all for your great questions. Just for such experts here on our panel, I feel like we've had some really fruitful discussion. I really hope you feel inspired and motivated by the talk that you've heard today. I hope it's left you with some questions, and I hope it's left you with just some enthusiasm to support us in some way. In the little booklets on your table, there's a slip that says about how you would like to stay involved, and there's lots of different ways. The list of critical needs is up here. We are more than just surgeons and anaesthetists. We need nurses. We need all of the supporting staff that actually make a hospital function safely and effectively and efficiently. So I would just encourage you, if you've got people that you think might be interested, just share what you've heard today with them. Encourage them to submit an application with us. There are a number of people in the room who are alumni, obviously the people that are on this stage, but there are also some others. So some people people will have blue lanyards on, and there's some people are in their Mercy Ships uniform. So if you want to talk to some of our hospital staff, then please, they would love to chat with you about their experience with Mercy Ships. I think that's something we can all agree on, that once we get on the subject, we tend to just keep going very enthusiastically about how much we love Mercy Ships. And once again, I just really want to, could we just have a round of applause for everybody on the panel and our moderator, Nate. We've got some time just to have some conversation, and then when you're ready to leave, if you could go through the door on the left, and someone will help you navigate your way off the vessel. Have a wonderful day.